All right, well, I'll tell you, I have to admit, I feel a little bit silly giving this talk here at this symposium because there really are some fantastic Indian surgeons out here that do an unbelievable volume. I'm a busy guy in the U.S. That's busy. I'm one of the top guys in the U.S. to do that many joints, but guys like Ashok, and I talk to them, it's just amazing the kind of volume you guys can do. So I commend you, and you must have it figured out. I think maybe you guys should be giving this talk instead of me, but I'm going to give you how I do it in the U.S. Of course, it's a little different than you guys over here. I'm a private practice surgeon, so I do every surgery, and I open and I stay until the capsule's closed in the knee and the deep sub-Q in the hip. I don't have residents or fellows. I have physician assistants, so they do the closing, the last bit of closing, but I don't have registrars or residents. And so there's a few surgeons who do more in the U.S., but they're often at universities, and they do have fellows or residents, and they can run concurrent rooms. In other words, they have 2 rooms going at the same time, but that's a bit of an issue in the U.S. currently. It's a bit of a no-no. But in any case, efficiency is key for me to be able to do the kind of volume of cases that I do. And why do we need to be efficient? Well, things are changing in the U.S. I know things are changing here for you as well with this announcement they made this week, but our healthcare reimbursement is decreasing, both private and government. We still have Obamacare, despite what President Trump said he was going to do. He's tried, but been unsuccessful so far in getting rid of it. I don't think it will ever completely go away, but that leads to more government or lower paying patients. We have pay for performance, so if you have complications or readmissions, you get decreased reimbursement, and we have bundled payments. And some surgeons, some groups like my group, we own the bundle. So we're given a certain amount of money to take care of the patient for 90 days. And if it goes well, we end up with a little extra money. If it goes poorly, complications, readmissions, it can actually cost me money to do the surgery. So they're putting the onus on us a bit unfairly, I would say. But the bottom line is, in order to maintain income, in order to maintain a reasonable balance of work and life outside of work, you have to do more surgeries, and you have to do them more efficiently with less complications. And I don't mean this in a denigrating way, but really, for me anyway, I do hips and knees. That's all I do. And we're just very kind of high-piece factory workers. We do piece work. But those surgeries we do over and over again lend itself to a lot of efficiencies. So you have to have a good foundation. You have to have a hospital that's on your side. You have to have dedicated anesthesia, dedicated nursing and scrub personnel, and you need multiple OR rooms, and that can lead to an efficient, happy surgeon. Your institution has to be on your side. They have to be your advocate. They need to realize the more efficient you are, the better they do. At least in the U.S., orthopedics makes the hospitals a lot of money. So the better you do, the better they do. So they need to facilitate your day. They don't need to obstruct. And then we have rapid rehab. We have skilled therapy. Everybody gets up to day of surgery, or we try, and 2 therapy sessions per day, including the weekends. And dedicated anesthesia. This is one of the most important things. Anesthesia seems to be one of the primary factors that limit OR efficiency. They can make or break your day. And I think if they have a production incentive, it's important. If you have employed anesthesiologists that are going to make the same, whether they do 1 case or 5 cases, good luck, because they're going to do 1 case. That's human nature. They're not going to push it. We'll skip that. How I do it: multiple OR rooms, separate crews for each room. It allows them to work at a comfortable pace. Their day's more enjoyable, and the predictability of their day decreases their stress. Again, anesthesia, it's one of the most important factors. You have to reward them, and they have to be on your side. So I have a separate anesthesia crew for each room. I typically utilize a certified nurse anesthetist rather than an MD because they seem to go faster. The MDs are out looking at their stock market, looking at the internet, whatever, so they're wasting time. The CRNAs, they're much quicker. We do a long-acting spinal with tetracaine and a little bit of Duramorph. Lasts 6 to 8 hours, excellent pain relief. We're still able to get the patients up the day of surgery. But it's imperative to put the spinal in pre-op holding. That's probably the most important factor. It allows your room to be turned over without interference. It doesn't take up costly OR time. But oftentimes when I tell other surgeons this, they say, well, anesthesia is excuses. The hospital, they say the hospital policy, we can't put a spinal in out in pre-op holding. It's unsafe. The patient needs additional monitoring. You have to have an MD there to monitor it. So in the U.S., we have a term for that. I'm not going to say it here, but I call them on it all the time because it is that term. Because think about it. I have long-acting spinals. All my patients go back to the floor. They have a full block when they go up to the floor. They're monitored by a nurse that has 3 or 4 other patients, and their vitals are checked manually. So if it's safe to send those patients back to the floor with a full block, there shouldn't be any problem putting a block in pre-op holding, because they're monitored by one nurse whose only responsibility is that patient. So don't let them give you that excuse. It can be done. Let's see, we'll skip that. Scrub techs, I know most of you, a lot of you work in just orthopedic hospitals, but a lot of us work in general hospitals with an orthopedic subset. So we have scrub techs that only do orthopedics. They become very efficient at scrubbing. It makes my day easier. I don't have to ask for things. I don't have to reach for instruments. I don't have to wait. It leads to consistency and less fatigue. It makes for a more enjoyable day for me and for the scrub. I run consecutive rooms. That means we're done with one surgery and then I go to the next room when we're done, not concurrent surgeries. If you do that, you have to be in the room for the important part of the surgery. It's easier if you do that with residents and fellows. But there's issues in the U.S. currently about that. You have to inform the patient if you're not going to be there for the whole case. They have to know that. And I schedule my joints for an hour. I utilize one scrub tech and one assistant. Surgery takes about 45 minutes, but I have to have time afterwards to go dictate, do my documentation. What I don't do, I don't see the patient prior to surgery. That wastes time. I send my PA out. They do the marking of the patient. And I don't see the patient's family after surgery. I just call out to the waiting room. We've warned them that's what we're going to do. I tell them the surgery has gone fine and no complications. And I tell them we'll see them all that evening when we come up for post-op rounds. And they're very happy with that. You don't have to waste time going out to see them. I put my revisions on at the end of the day. They're longer cases, less predictable. That keeps your day moving smoothly if the last case goes long. So it doesn't affect your entire day. And timing is important. Getting the spinal in, getting the patient in the room, prepping and draping. My goal is to walk from one room to the next, have the patient draped, ready to start surgery. It's a bit of a ballet to get it. So just a video here. The sync is just a little bit off, but I'm in the background there. I'm going to walk out of the room in a minute. By the time I get done dictating and all, they've already got the room cleaned up. And now I'm in the other room, magically, up here in about 1 second. So I'll start the other case. And we're going to run short of time here, so I'll have to cut this short in a bit. But I want to get through just a little bit of it if you give me just a little extra time. So we're working on the other case. The anesthesia provider takes the other patient out, drops him off in post-op. They go immediately over to pre-op, and they start working on the patient, so there's no delay, because they don't have a lot of time. I don't know how like ASHOT can do this in 30 minutes. I'd love to learn how they can get everything turned over in 30 minutes. But right now, I'm working on the acetabulum. I'm going to be reaming here. So that's about 10 minutes into the case, and they're working on the spinal to get the spinal in. So they get to the patient pretty quickly. So get the spinal in here. Sorry, but I should have edited this a little bit shorter. But once the spinal goes in, then they take the patient immediately into the room as we're working. And they know the timing. The scrub nurses know the timing. They know, and the CRNAs, they know to just go over and start the spinal. They don't have to wait for us. We don't have to tell them when to start to do this. And now they're bringing the patient into the room, and I'm putting the femoral component in. That's about the timing. Once they get in the room, it takes us about 15 to 18 minutes to get the patient ready, because we have to, with a long spinal, we have to put a Foley in. So it takes them a little bit of time to put a Foley in, get them on the table, get them turned, or get them prepped, get the tourniquets on. So now I'm done, and they've got the patient there. We'll go just a little bit longer, and then I'll cut this. But by the time I sit down and dictate and make my calls, they'll have the patient pretty much ready. I like to think of this as a term I like to use. I was an engineer in the past, and many of you are probably engineers. There's a term called duty cycle. And duty cycle means how much of the time the switch is on, or how much of the time you're actually doing something. And my goal is to have a duty cycle of 100%. When I go to the OR that day, I want to be working the entire time. I don't want to go to the OR lounge. I don't want to sit down. I don't want to wait. And there's a lot of surgeons, especially in the U.S., their duty time is less than 50%. They can do the case faster than it takes them to turn over the room. So they spend most of their day waiting, and that's terribly inefficient. So I'll stop this now. Trust me, when I walk up here, and by the time I get washed up and all that, they've got everything here ready to go. And So I'll stop there. We do run, just a couple of words about office efficiency. When you do that many cases, you have to see patients. It's a little different in the US. I got to see all my patients. They're not happy to just see my residents or PAs. They want to see me. And on my clinic days, I see about 60 or 70 patients. When I'm in the OR, I have at least 1 or 2 PAs in the clinic seeing patients even when I'm operating. So they see post-ops, they see new patients. So that keeps patients rolling through. And my research nurse, she comes down 1 day a week to see post-ops, fresh post-ops. So she sees about 20 plus patients of our fresh post-ops. That unloads me. And so the bottom line is it takes a team. You got to have people that are bought into this. If you treat them well, if you pay them well, they'll be loyal to you. They'll make your life a lot easier. You have to get anesthesia to buy in. That's key. Thank you.